In the few minutes before we start, as I said to some people who joined just at the beginning there, if you could take a moment to introduce yourself in the chat by name and by role, it gives a better feeling about who's actually on the call. And the idea of this session is that what we're going to do is take you through a high-level view of the CLEAR program, and then we're going to go through quite a fast-paced interactive taster session, which will give you the flavour of what a CLEAR project actually involves. And for that second part of the session, it's going to be a little bit interactive using something called Slido, which is something that you can use on your phone. So a QR code, when John shares his screen in a minute, is going to pop up. So if you could use your camera on your phone to scan that QR code, it will let you interact for the more interactive part of this session, which will be the second part. If there's any problems with that, then don't worry, we can also use the chat function as well. So just to kick off, I'm going to hand over to John, who's going to take us through a little bit of a background to the CLEAR program and give you a kind of overview of where the program came from and what it's getting up to at the moment.
Much, Alex. I'm shortly going to share my screen to just go through some slides. Sal, I don't know if you could just enable it for me. But what I'm going to do is just go through a little bit about where the CLEAR program came from, what we're currently doing as a program nationally, and then hand over back to Alex to go through this mini taster session. Before I get into detail about what the CLEAR program is, what I'm going to do is just talk about where it came from and why an anaesthetist would have an interest in workforce redesign and workforce modelling, because it's not an actual career path for most anaesthetists. It's something that I kind of fell into, and the reason that I fell into it is because of an experience I had with my dad, where he got care that isn't the kind of care that we would want our colleagues or patients to have. It was about 7 or 8 years ago now, and he had a diagnosis of a gastric cancer, and his care right from his diagnosis through to his death. There were some fantastic things about it, and some people did give him some really, really good care, but there was elements of it which weren't, well, just it wasn't needed to be. And that was right from his diagnosis, which was delayed, through to getting his operation. It was interesting at that time in London, your 5-year survival varied between 15 and 50%, depending upon which surgeon you went to. And obviously, being in the NHS, I was able to find out which surgeon was the right one for my dad to go to, and then obviously ensure that he could see that the right surgeon, and got a good operation initially, even though it was delayed a couple of weeks because there weren't enough ITU beds. And after he had his operation, he then ended up having some chemotherapy. Did reasonably well with the chemotherapy. Unfortunately, had a neutropenic sepsis, which popped him back into hospital. And then I actually did quite well for about 6 months. And unfortunately, he did get an early recurrence, and he did end up passing away. And the thing that sticks most in my mind about his experience is the way that he died, because he wanted to die at home, and it was incredibly difficult for us, my family and I, to enable that to happen. It got to the point where he was sent home from hospital, and a syringe driver was delivered at the house where he lived the very next day. But there was no medications or no one to help us set it up. So we ended up having to get the out-of-hours GP to come around, give us a prescription where my wife, another anaesthetist, and I popped off to the out-of-hours pharmacist, where we got a range of different vials of medication, and came back to the house and then got on the phone to the hospice. And the hospice was able to coach us through the process of setting up the syringe driver and looking after him, enable us to look after him at home for the next 10 days until he passed away. And the thing that sort of took me most by surprise with the whole process was that 2 days after he died, the palliative care team came round and asked if there was anything they could do to help. And I walked away from that experience feeling a bit miffed, and generally quite upset. I suppose that miffed is a nice way of saying I was genuinely very, very upset. And because I could see all these good people in the NHS working so hard to try and look after patients to make sure that they could get good quality care. And yet for people like my dad, and I'm sure there's many others in the system like him, it just wasn't possible for him to get the care that he needed. So I could see myself becoming that grumpy colleague in the corner, and I didn't want to be that person. So I took some time away from clinical practice, got involved in a very haphazard manner in this workforce modeling project, and I learned loads in the subsequent year and a half. A lot about data, because I do like a little bit of data, but also about how if you can combine data with good quality conversations, you can help people redesign models of care and workforce so that patients like my dad can get a better care. And so after doing that work for about a year and a half, 2 years, I came back into clinical practice. I've been part-time ever since and started to do various projects across the NHS, helping colleagues use data and good quality conversation to redesign models of care and workforce. And after doing a couple of projects, I was very fortunate that HE came along and said, oh, John, this is really interesting work. Do you want to try and create a training program so that other clinicians can do this type of work to improve patient care and outcomes? And that's where the clinically led workforce and activity redesign program, or CLEAR program, came from. So CLEAR at its core is a work-based learning program that trains clinicians to work collaboratively with staff from a range of different backgrounds, HR, finance, workforce, operational management, to use a combination of big data analysis and qualitative techniques to deliver projects that address key national, regional, or system or organizational priorities. And the purpose of the program is to create a self-sustaining community of practice of people who can do this type of work across a range of different disciplines, who can improve patient care experience and outcomes, and also as a sort of positive byproduct, create portfolio careers for NHS staff, because we know that improves recruitment and retention. The aim of the program is to create a clinically led culture that works collaboratively with a range of different disciplines, where we build new skills in colleagues that can drive new ways of working, and also give clinical ownership to any change, because one of the things, especially when it comes to workforce redesign, is we need operational buy-in and clinical buy-in for any changes that need to take place. So that's what the aims of the program are. And how this supports the NHS is it enables the NHS as a whole to improve recruitment and retention via the development of careers, transform delivery to manage demand, and this is going to be something that is going to need to happen. Well, I mean, we all know it's going to be a huge priority across a range of different clinical areas over the coming years. And by transforming delivery to manage demand, they can thereby improve access to services, and most importantly for me, build collaborative working across organizations and systems that enable this to happen well, so people like my dad don't slip through the net and get good quality care. The program as it stands is sponsored by HE and NHSEI, and we're a hosted program at East Lancs Hospitals Trust, and we're doing projects in ophthalmology, critical care, mental health, urgent emergency care, and anticipatory care across the country, training quite a few people, and obviously doing lots and lots of projects with. And the key thing I suppose to mention is that we're very much a project-focused program, because it's the projects. The training is vital, because we need to have skilled colleagues to do this work, but the projects are really important because that's where you get the outcomes to improve patient care. CLEAR as a program has multiple different projects, and each project follows a standardized format. The first is clinical engagement, to understand the scope and of any key challenges that a system or organization is facing. Once the clinical engagement is done, and that involves generally interviewing between 20 and 40 people, running workshops, 4 or 5 workshops in a given process, and engaging with key stakeholders across systems. There's then the data interrogation phase, where the inductive, thematic, qualitative analysis, which is basically the outcomes of the process of clinical engagement, is then compared with the big data analysis with the program. There's then a safe space created for people to innovate and redesign the model of care, And then after that, there's recommendations are developed, and these are disseminated at the appropriate organizational system, regional or national forum. When we're doing the clear projects, we can either do the projects as part of the national faculty hosted at East Lancs, or we train people, which is the most satisfying element of the work that we do. And there's a standardized 24-week training program that clear teams do that engage in and do their projects across systems. It's quite a busy slide. I won't go through it in too much detail, but it's just suffice to say the first 8 weeks are about the clinical engagement. The second 6 weeks, so up to week 14, is about quantitative data analysis. And then there's an innovation phase for the next 4 weeks, followed by the recommendations and dissemination, which is up to week 24. I'll stop sharing my screen now and hand over to Alex, who'll be able to give us a taste of what all of that looks like in practice over the next 20 minutes or so. Over to you, Alex.
Thank you, John. Just before we move on to this part, there was a little bit of difficulty with some audio from some people. Can I just check that everyone's able to hear us at the moment? If those audio problems have been resolved? If not, put something in the chat and you can hear me. Okay, that's good. Perfect, thank you. So the next part of this session, essentially, we're going to put you in the driving seat to run through a very, very quick, clear project, give you a bit of an understanding about what it's like from the perspective of a participant in the program. So I kind of want you to get into that headspace at the moment. And Charlotte, I think, is going to kindly share some slides. Are you on that, Charlotte?
Yeah, can you see this okay?
I can see it, yeah, it's come up now. Thank you. So if you go on to the next slide, so essentially we're going to run through these 4 different stages to a clear project. So as John said, there's this clinical engagement stage, then you go on to this data interrogation, then into that safe space for innovation, and then finally into the kind of recommendations for change. And if you go on to the next slide for me, Charlotte, thank you. So to start, it's excellent news for us that you've joined the CLEAR programme. And as a participant on the programme, you've had your induction, you've completed some training, and you've been matched with a project that's going to look at the emergency department at a hospital that's called Goodwill Hospital, which is very like any other hospital in the NHS. So the first question that we'd like you to consider is that when starting this project, before you even start, what kinds of things would you like to know about Goodwill Hospital? What I'm going to ask you to do now is take your camera, your camera on your phone, and scan this QR code, or go to the website slido.com and go to #ClearTaste. And you'll be able to enter in any of your thoughts as to answers to this question. So just throw anything out there. What kind of thing would you like to know about Goodwill Hospital before you start? How big is the hospital? Yeah, absolutely. What are the biggest staffing challenges? Very good. Any other things that you'd like to know? Services offered, yeah. Workforce numbers, profiles, so quite a lot of kind of data about the hospital, feedback from patients, all of that kind of the documents behind the hospital, CQC reports, how old it is. Absolutely. Okay, anything else there? You scroll down, agency use, yeah, so kind of thinking about workforce, what the situation is on the ground, what their waiting time, so things like some of the key performance indicators from the hospital, absolutely. So there's an awful lot of information that you can gather even before going to the hospital. And so that is where we really start with some of these projects. We start by reviewing a lot of the information that's publicly available. There's CQC reports out there. There's information that the hospital can share with us before we even start. Population size, mortality, levels of sickness, absolutely. That's great. Thank you, Charlotte. So if we go to the next slide. So what I can tell you about Goodwill Hospital before you start your project is essentially that it has a type 1 emergency department, so it's consultancy-led services. It serves a population of 500,000 and has an average of 200 attendances per day. And from your conversations with the clinical director, you find out that these increased attendances, like many of the EDs across the country, have led to departmental overcrowding and an increased workload, which has subsequently led to kind of suboptimal experience for patients and a difficult working environment for staff. So a project at this hospital trying to address some of these challenges is going to be really beneficial. So I hope you're all very excited to get started with this project. So moving into the first phase, the clinical engagement phase, and having read all the documents that have been given to you, you're ready to kind of get cracking. And the aim of this phase is to gather rich, qualitative data about the service. So kind of qualitative data is the type of data that we talk about when we're thinking about qualities or characteristics. And you gather this information by talking to people. So for our next question, given that this project is focusing on Goodwill Hospital's emergency department, who do you think are going to be the most important people for you to talk to? If you kind of had a brainstorm of all the people that you should be talking to get started and get this information, who are you going to try and talk to? The patients. Who else? Patients is coming up big, excellent. Admin staff, porters, definitely staff, doctors, managers, nurses, the clinical leads, the board, carers, porters, diagnostics, GPs, district nurses, students as well. Brilliant. So yeah, so in this kind of engagement part, some great thoughts coming out here. What we really want to do is identify all the people who are involved in leading, delivering, or interacting with the services. So it's a very wide range of people, as you've said here. And as you say, they could be service leads, it could be clinical staff, and non-clinical staff as well. It's very important, kind of all the support staff as well, the porters, administrators, pharmacy, everyone who interacts with that emergency department, because it absolutely doesn't sit on its own. It interacts with every other part of the hospital and also organizations outside of the hospital. So really important to have a really wide range of different people to talk to. One of the key things that you've put there is patients, and patients certainly are obviously who we're doing a lot of this project for. One of the things about CLEAR is that we don't currently engage directly with patients, and that's due to kind of some of the ethical and governance issues around directly engaging with patients. However, it is something that we are working out to have a kind of considered way to approach this. So in the future, we're going to be more directly engaging with patients, but currently we do not. But everyone else absolutely will be engaging with. So if you move on to the next slide, thank you. So now that you've identified who you're going to speak to, you're going to use a series of qualitative techniques to work out how to engage with them. So these could be interviews, they could be focus groups, they could be informal discussions. And the data that you get from this is going to be really a rich description of how Goodwill Hospital is functioning. So what's working well and why, what needs improving. So you speak to a lot of people and you're going to bring together all of these contrasting opinions. And it's really key to make sure that you do get those contrasting opinions so that you get all the different arguments and viewpoints. You'll get to a point where you realize that you aren't hearing anything new in the interviews. At this point, we call data saturation, and it means that there's no new information coming out. And so interviewing people further is not expected to actually enhance or change any of the findings that you get. And at that point, we start the analysis that John was talking about. So you've now, being highly efficient, obviously, you've now completed all of your engagements, and you've started to look at the data that you've recorded. And that data, because it's interview data, kind of comes as quotes essentially. And so what you've got on the screen now are a few quotes from some of the staff who are working at Goodwill Hospital. What you're then going to do is something called an adapted thematic analysis. And it's an approach to analysing this data. And broadly, what it involves is reading through and kind of saturating yourself in the data, but reading through the data and pulling out the main themes that are emerging from that data. So what I'd like you to do now is take a moment just to read through some of these quotes that are on the screen. And if you can think of any themes that are emerging there, then write them down in the Slido. And there's no real kind of wrong answer to this, because it's definitely, qualitative data is all about perspective. And so if you kind of write down the themes that you think are kind of coming out from those quotes. It might be a harder one to do, Charlotte, if they can't see necessarily the quotes. But frail elderly patients is definitely one of them. Patient experience, yeah. Increased risk to the elderly. ED not the best place for these patients, yeah. Out of hours. Complex care, definitely. Admission process. Yeah, there was a lot about it not necessarily being the best place for the frail elderly, that they were staying there a longer period of time and then they were getting admitted. System problems, so yeah, kind of stepping back and looking at the wider issues. Referral pathways. Yeah, so definitely, so the biggest things kind of coming out, the complex care, admission process for these patients, out of hours issues, access to certain, brilliant. Well, that's absolutely spot on. And essentially when you're doing that qualitative data analysis, as a participant, you work in a team who are all kind of looking at and immersing themselves in the data together. So you build up these themes. And what we tend to do is kind of do a first run through where we pull out what you've done here, which is essentially kind of thinking about the codes. So the first themes that really jump out at you. And then you build them into families. So similar codes all end up in these families of codes. And these families of codes are then used to describe the key themes that are really emerging from this data. And that really gives you a rich understanding and process to understand what the key messages are that have come out from all of your interviews. So if you go to the next slide, please, Charlotte. So we're going to move on to then the data interrogation phase. So you've completed your clinical engagement, you've got all your themes out, I think you've got a really good comprehensive understanding about all of the issues at Goodwill Hospital. What you then are going to do is data interrogation. And this is particularly looking at what we call the kind of quantitative data. So this is data that includes numerical values. And in this case, it's related to patient activity data that has been gathered from Goodwill Hospital. And I'm going to ask John to take you through just a couple of the things that you'll find, because this section, the data interrogation, can take quite a long time to do. So he's going to kind of synthesize a couple of the findings that you will find in your data interrogation phase.
Thank you, Alex. And just actually before I move on to this, Debbie's asked just a question that's probably worth tackling now, which is, in this particular example, were the interviews targeted around elderly patients, or did we ask general questions and then look for themes? I don't know if you want to pick that one up.
We can definitely pick that one up. So the interviews were kind of general themes. So not directing those interviews in any particular way. But the examples that we had just for that previous one were the ones that have been grouped together for frail patients. So it was probably what you were seeing was a subsection of the data which was similarly themed.
Yeah, and I think that's a very good point, because normally people come out with many more themes than just frail patients. For the sake of this presentation, we've just tried to hold true to the process and keep it manageable. When normally these projects, when they finally report, come up with reports that can be 30, 40, or sometimes up to 70 pages long, looking at the range of different themes and potential solutions with different recommendations and data to support business case and the like. So we're going through this at a very high level. There's loads more that can be done. And actually on that note, I'll sort of, when talking about the data, I'm going to go through this data in 2 or 3 minutes. Normally when I start speaking about data, it's at least half an hour to 40 minutes to go through all of the bits and bobs associated with it. And there is a talk on Wednesday afternoon where I will do just that for the interested, for those who are very interested in data. But in terms of the data interrogation related to this CLEAR project, what we do is we take de-identified or pseudonymized patient level data from trusts and again, effectively anonymous staff level data from trusts. And this is then uploaded into a cloud, which is a set of computers that are in Berkshire. And it's then the data spun around and twisted in various different ways using some couple of different types of scripts in Python, SQL, etc. And then there's a visualization layer layered over the top of this data. And what the visualization layer allows you to do is to interrogate the data to determine if the things that you found in the qualitative analysis are truly present in the data. And so in this particular scenario, if we're looking at Goodwill Hospital, what we're finding in the data is that if we look at all of the trust or all of the department and the 150,000 patients that pass through it over 1 year, overall, the flow of patients through the hospital is actually not too bad. What you're seeing here is that patients are admitted either via, at the top left bar, they're admitted via a walk-ins, and in the bottom left-hand block, they're admitted via ambulance. And as you can see, at least half of patients, almost half of patients, are discharged after 2 movements through the department. And there's quite a few big yellow and green high volume patient pathways, which is generally a good sign because generally high volume pathways lead to high levels of standardization, which leads to low levels of variation, which generally means better quality outcomes for patients. But what there is what it is worth noting is that from the ambulance pathways in the bottom left-hand corner, there's lots of small squiggly purple lines. And these small squiggly purple lines seem to have multiple movements through the department before being admitted, which is the top right-hand box, or discharged, which is the bottom right, which is the right-hand box in the middle, all the way at the side. And so what it does suggest is that there is a cohort of patients that would benefit from further interrogation, specifically those that come via the ambulance. And if we move on to the next slide, what you'll see then is that the analytics filtering down onto those patients that are frail. And what you can see here, and the way that you codify this is use a combination of age and other scores within the base data to determine whether or not a patient is likely to be frail. There's no one perfect answer for if someone is truly frail. So what we encourage people to do is to look at the data from multiple different lenses to pick it up. But on this particular lens, what you can see here is that if we look at the patients that you can classify as frail, there's about 15,000 patients that are flowing through this one site over the course of a year, and that there's a lot more fragmentation of the pathways compared with the previous visualization and analysis of the data. And what this is showing you is that there's much higher levels of variability and also the patients are having multiple movements through the department before being either admitted, which is a much higher proportion here in the top right-hand box, or discharged. And the combination of all of this indicates that there's significant potential to redesign both the model of care and the model of workforce that's looking after this patient cohort. And the how of that, obviously, I'll take everyone through who's keen on Wednesday to show some more of the analytics. But if we move on to the next slide, what we'll be able to just see is that, and you'll have to sort of trust me on this one, is that if we were to look at other bits of analysis in the analytics, we can see that the numbers of frail patients have gone up over the previous 2 to 3 years. Over a third of the patients are breaching 4 hours, and quite a few are there for more than 12 hours as well. The high admission rate, and there's a high number of investigations, 7, 8, 9 investigations for this patient cohort, but only 1 or 2 or sometimes 3 treatments. So you're taking a group of people who's frail, they're coming into a environment which is a needy environment, which I think we can all agree is not necessarily the best place for them to be for a long period of time, and they're staying a long period of time. But if we look at the data in more detail, they actually don't spend that long in hospital. And there's a high amount of pressure from this patient cohort on Fridays through to Mondays, and then lowest in the middle of the week, which is associated with the presence or absence of community services. Interestingly enough, if we were to go through the data in significant detail, there's also some evidence that there's an absence of sufficient staff to look after this patient population between the hours of 10 and 1, with waiting times to see the relevant number of staff as up to 3 hours. So the moral of the story is that if we compare what staff feel is happening on the front line, and then look at the data, there's a range of different evidence. There's a lot of evidence to back up what people are saying. And then there's some very helpful things that can be done about it. I'll hand back over to Alex to discuss that in more detail.
Thank you, John. So now that you've done your clinical engagement and pulled out all your themes from that, and John has done your kind of data interrogation and brought out all the themes from that, you've then gone and presented these findings to all the stakeholders at Goodwill Hospital. So everyone has essentially agreed on what the challenges are, and you've got a really good idea about what it is that you should be going to try and solve. So you now have the opportunity to get everyone to think outside the box and contribute to some potential solutions. And this is what we call the innovation phase. So for our next question, what we're going to ask you to do is write down any potential solutions that you can think of. And at this stage, we're trying to think very big, very innovatively, try not to be constrained by practicalities, because we try and go as big as possible. And then at a later stage, kind of bring it back down to plausibility and viability. So anything that you could think of that would help support this, the challenges that, or address the challenges that you've heard so far. Particularly, I guess, thinking about that frail elderly population. Fantastic. We've got some ideas: a frailty unit, a rapid response team, out of hours community service, GP referrals, pharmacy open 24/7. And to kind of start thinking about this thing, sometimes we ask people to think as though they were someone else. So if you were Elon Musk, what kind of solutions would you come up with? If money were no object, what kind of solutions would you come up with? That kind of thing. So really putting it out there. Elon Musk would probably, I don't know, send someone into space. But really kind of thinking big as though there weren't any constraints. Social care access on site, so definitely kind of having some much closer relationships with social care. A separate unit. Digital health solutions. Yeah, really getting underneath doing things more digitally. One-to-one support for the frail. Improving community services, a virtual ward. Excellent. So some really good ideas kind of coming out there, and this kind of phase of the program is really about kind of trying to think outside the box. And as I say, you're going to be creating options of varying plausibility and viability. So this list would need to be kind of developed into more workable and implementable solutions depending on the actual constraints. But the first starting list needs to be as big and broad as possible to get people really thinking about potential options. Fantastic. Well, thank you for that. But if we go on to the next slide. So essentially after more multiple sessions, you've gone through this, you've created your workable solutions and more implementable solutions and talk to people on the floor. One of the big solutions that you've decided to recommend is a new frailty unit. And in this case, the unit would seek to provide 7-day multidisciplinary frailty service to support early identification and assessment of frail patients and avoid unnecessary investigation and admission. So obviously there are other ideas out there, and thinking about new roles, new ways of working, new processes that may also be explored alongside this and adopted as part of your recommendations for this project. You'd then go on in this kind of part of the program to detail exactly how this unit could work and the anticipated impact of investment into this unit. So how much it would actually cost to create a unit such as this, how you could potentially staff it, with what roles, working in what manner. And then that kind of all comes together in this final phase of the CLEAR project. So at this point, the focus would be on clearly articulating what your recommended intervention is. So in this case, the frailty unit, and ensuring that it's socialized with all the relevant stakeholders, that your hard work on this project has the impact that it deserves. So really making sure that the project lands and can be taken forward. So as a final question, I'd like to ask you, what do you think, or who do you think are the most important people to present these findings to and get support from to make sure that the recommendations are a success? The board, yeah, definitely. Who else? Finance, directors, commissioners. Everyone we spoke to before. I think that's a really good point, because I think certainly we absolutely, in order to get anything moving with it, the board needs to be on board. But also everyone who's been involved in the project so far and engaged from the very beginning will need to also be kind of very on board with the outputs of the project, because the way in which this is actually going to happen and be totally bought into is if you have the support of the frontline staff. So absolutely talking to everyone is going to be involved there. Fantastic. So we're getting quite a long list. So as you can see, it's a big chunk of engagement at the beginning of the projects. We kind of continue engaging throughout and developing these ideas, socializing these ideas. And at the end, it's really important that everyone who has been involved in the journey is also aware of and supportive of the kind of the outputs that come out the recommendation stage. Fantastic. So that is going to be the end of your CLEAR project. You're going to talk to all of these people. You're going to socialize the recommendations. And at the end, you will have created a report with the details behind those recommendations. So the kind of how you could potentially do it, what the options would be, and the impact of actually completing that recommendation. So thank you for that, Charlotte. I'm going to hand back over to John, who's going to kind of finish up and do some kind of questions, I think.
Thank you very much, Alex, and also to Charlotte for keeping everything moving there. So this has sort of come to the end of this particular talk, but hopefully it gives a flavour of what a CLEAR project involves. It's, I guess, very important to sort of state that as a program or as a project, if we were doing this all together in a particular organizational system, we would be doing this alongside up to 6 or 7 other projects that would be going on across a system, regional, nationally. And so we'd be sharing our thoughts and our learning with colleagues doing this work in other parts of the country, so that we could get the most from this work and ensure that it has the maximum impact from the patients and share learning. The other key point to make is that these projects are done as teams. And so a normal clear team doing this project may be a clinical director, a matron, a paramedic, a nurse, an allied health professional, all working together, all doing the clinical engagement, all doing the data analysis, all doing the innovation, and then the findings and recommendations, and then presenting them back at the appropriate fora, which is Legion, as we've just discussed. There's it's just a final point for today. This is a very sort of simple thing that we've gone through over about 20 minutes to half an hour. The projects themselves can be very, very complex, with multiple different themes emerging, multiple different solutions that need to be implemented. And some of them can be done so quickly and get implemented whilst a project is ongoing. And some of them can be so incredibly complicated and will require separate business cases to go through. So, you know, one of the projects that was done just prior to COVID was contributing to a full front of house A&E redesign with new estates and a new workforce model for the whole area. On that note, I'll stop talking, but I just want to say a big thank you to everyone who's joined today, and to see if there's anyone who's got any questions. I can just see Claudia just asked a quick question in the bottom right hand corner, but Charlotte, I don't know, Suman, I don't know if I've missed anyone else. But Claudia, you mentioned blue sky thinking during the innovation stage. How much filtering of realism would you do before taking to recommendations? Very good question. The reason we push the boat out quite hard when it comes to blue sky thinking is because people, especially, you know, for me in my clinical practice, I want to stay very close to what I know, because that's where I feel safe, and because my care has a direct impact on patients. I don't want to stray too far from that. So we really push people quite hard to think as broadly and as differently as they can. And then once they've done that, we then get the ideas to be socialized initially within the CLEAR team, then across all the different CLEAR teams, and then with colleagues and key stakeholders and staff prior to going to full recommendations. So that is I hope that answers your question, Claudia. But please, if I have missed any points, don't hesitate to ask again. And Charlotte or Suman, have there been any other questions that I've missed? No. Okay. Well, I think in that case, we've got 45 minutes. If anyone does have any questions, can always drop us a line at any moment, at any time, on the email that's in the chat. And it's great to see everyone here today, and look forward to seeing people in the not too distant future. Thank you all very much and have a great day.